Hello, and welcome to OvaryActive. I'm Dr. Rebecca Dunsmoor-Su.
And I'm Dr. Amy Voedisch, and we are your expert guides on the strange and often uncomfortable journey that is perimenopause. Welcome back to OvaryActive, everybody. This is Dr. Amy Voedisch.
And I'm Dr. Rebecca Dunsmoor-Su. And today we are actually going to address something that's been in the news because I think when things hit the news, we need to talk about them.
Yes.
Because, reporters are looking for a great headline. So they're going to find the scariest thing they can take out of a paper and put that right up front and not explain the rest of the paper. But that's why you have us.
What's so fun about a podcast is that we get to take headlines and then respond to them, not exactly in real time, but relatively quickly, which is kind of fun.
Today, we're going to be talking about IUDs, specifically levonorgestrel IUDs. Some people know them as the Mirena or the Kyleena. They have a lot of names. There are many of them on the market. And do they increase your risk of breast cancer? Because the New York Times had a great article, just kidding, about how there was a research article that said, yes, they do. And they sort of left it at that.
Right. So scares the absolute bejesus out of anybody, the millions of people who use levonorgestrel containing IUDs. And unnecessarily, I would say, gives them concern. So I think it's really important to kind of break this study down to kind of go through what did the study show, what's happening, and kind of the main take-home points is how does this impact you, the listener? What do you really need to be worried about? Do you need to be worried about this or not worried about this? So it's our job to break it down for you so you know what you need to do for your own health.
We're actually going to talk about two studies because they did two very, very, very similar studies looking at the exact same outcome. We'll talk a little bit about how these studies were done. But I wanted to start by centering us on some facts.
Ooh, I love facts.
I like facts too. So basic fact number 1 in 8 women will get breast cancer. That is the baseline rate of breast cancer in the US. But it's not even close to the number 1 killer of women. And in fact, one of my favorite facts, women who get breast cancer are more likely to die of heart disease than breast cancer.
Let's repeat that because I think that's really important.
Yeah. Women who get breast cancer die of heart disease. Most breast cancer is caught very early because of routine mammographic screening, and we cure it. And women go on and live long and healthy lives and die of a heart attack or a stroke.
Or any of the other number of things. Breast cancer, it's scary. It's really scary to get that diagnosis, but I think it's also something that has been hyped up so much that people are so afraid of it, when really, like you said, we need to be thinking more about things like heart disease because we're more likely to actually die of heart disease than we are with breast cancer. But it's still really scary. And it's one of those things that people really focus on. What can I do to kind of prevent my risk of breast cancer? Because that's the thing that they think about. It's more in the forefront of their brain than something like heart disease.
Right. And I think also, treatment's no joke for breast cancer, whatever that treatment might be.
Yeah.
But it's a point in time. And I say this from personal experience. You get through it and then you go on and live your life.
But at the time, it sucks.
Yes, I can attest.
Yeah.
We also know that there's a link between progestins in general and breast cancer. That was the whole big thing that the WHI, another great headline, don't get us started. That's what the WHI told us. And we've had subsequent studies that tell us this. And in general, when looking in postmenopausal women, which these studies do not, so we're going to make that distinction. But when we look at postmenopausal women using menopausal hormone therapy, part of which is a progestin, we see an increased risk of breast cancer that accounts for about 1 additional case in 1,000 woman years. And I'm going to explain that because when we study things, we don't necessarily have 10, 15, 20 years on each woman. We have a number of women and a number of years that they were each followed. So we make this averaging that we call woman years. So years that a woman has lived, it may not all be the same woman.
Right. They kind of compile all the data together so that they can make some sort of statistical analysis or some kind of idea of what your increased risk is. And I want to back up just a second. When we talk about progestins and what do we mean by progestins? When we think about hormones, and I just love talking about hormones, when we think about hormones, really the two main players that we're thinking about for perimenopause and menopause are estrogen and progesterone. And we have medications that work at both of those receptors. So in your body, you have a hormone or an enzyme or a protein or a something. And the way that that particular molecule interacts in your body is through receptors. So there's things on, like, for example, on your brain where the estrogen can go and then attach. Think of it like a docking station in like sci-fi movies
That's a great analogy.
where it docks and then it impacts what happens in that particular organ. And when we look at hormonal therapy for women, it's often a combination or could be solo. So it's usually a combination of an estrogen and a progestogen. And so, example, like a birth control pill would have it something that would work at the estrogen receptor and something that would work at the progesterone receptor. So that's kind of a general overview of what we're talking about with estrogens and progestogens. And progestogens is the kind of umbrella term that we use for any compounds that work at the progesterone receptor, but there are different kinds. So one kind is something called progesterone, which is what our ovary normally makes. And we also have that available as part of our menopausal hormone therapy. And then there's progestins, and progestins also work at the progesterone receptor, but those are slightly different in formulation and are what we typically find in birth control methods.
And there are many of them, levonorgestrel being one of them.
Right. And levonorgestrel is the type of progestin that's in the hormone containing IUDs that are available here in the US.
No, that was a great sidebar because I think sometimes I tend to forget that not everybody, I just roll with progestins and figure everybody understands what that is,
Yeah.
right?
Well, now our listeners are going to know, and they're going to be able to roll this out at a cocktail party and be the single most popular people there. So that's what I'm saying.
Well, there you go. There
Yeah.
you go. So back to the statistic. I said one additional case of breast cancer in 1,000 woman years. That's not a huge increase.
No.
And when I explain it to women, I tell them, there are two compounds that have been studied that probably cause more breast cancer. And those are red wine and red meat.
Oh, my two favorite things.
I know, exactly. But we don't tell every menopausal woman to stop taking those in.
Right.
And they probably have higher rates of breast cancer than even a progestin. So it's just about risk benefit balancing, right? Is there a benefit you're getting from this that outweighs that small increased risk?
Right. When something is really common, for example,
Like breast cancer.
because it is very common, we can pick up nitty gritty little details on things that could slightly increase the risk. If something isn't very common, it's difficult to study, it's hard to know. But when something's common, we can get down to sort of minute details that maybe clinically aren't super significant, but we can still sort of tease that information out. So I think that's important to think about as well.
These progestins are in all the birth control pills we use. And we don't do a lot of talk about birth control pills increasing cancer risk, right? We don't talk about them increasing breast cancer risk. So why would the IUD do it and the birth control pills not do it? The answer is they may also, because they contain progestins, very slightly increase risk. But when we're counseling on birth control, we're balancing two sets of risk. What is the risk of using this birth control pill? And what is the risk of getting pregnant?
Right.
And the risks of pregnancy are huge for women. There are risks of blood clots. There are risks of hypertension and hypertensive diseases.
Mm-hmm. Yep. Bleeding disorders, hemorrhaging, blood transfusions.
And death.
Yeah.
So we have to balance those things.
Right.
And on balance, birth control is a hell of a lot safer than getting pregnant over and over.
Absolutely. Yep. Absolutely. Every time you get pregnant, it's a risk. And I think we don't think about that. And so I've had so many patients come in and, well, my doctor says I can't be on birth control because it's too risky. I'm like, would your doctor like you to get pregnant? Because that's going to be 100 times worse. Guarantee it.
Yeah.
And they're like, oh, I hadn't thought about it that way. I'm like, yeah.
Pregnancy has a wonderful outcome if it's a planned pregnancy. We love our children.
We do.
I think birth control has done a huge amount of good for women around the world in terms of spacing pregnancy and managing pregnancy, and women not dying in childbirth with their 8th, ninth, 10th child
Right.
because they had no option but to have those children. So
Right.
just a little perspective
A little, yes, a
before
little
we
side.
step into the study.
Oh, I'm very excited. So the name of the study, because I know you're all dying to hear it, it's really going to change your life, is the Association of Levonorgestrel Releasing Intrauterine Device with Gynecologic and Breast Cancers, a national cohort study in Sweden. And it was published in the American Journal of OBGYN. And I do have to do a little shout out to my heritage, to the Swedes. It's always nice to see my home country adding to the medical literature.
Yes. And, we see these studies happening in countries like Sweden and Denmark and places
Finland.
like that, and Finland, because these countries have nationalized healthcare. So every prescription is linked to every outcome for every person because
Right.
it's all in the same database because everybody has the same healthcare. That's not the case in the US. So we often see these studies come out of countries like Sweden. This can be great. We have a huge database with all the information in it. There are also downsides because these huge databases don't have all the information in them. So we don't know everything that might confound, as we like to say, the outcomes. And those are risk factors that we may not be able to account for. The other downside is this generalizable to the US population? And what I mean by that is in Sweden, people look one way and live one way. And in the US, we look different and live differently. So there's some question about how does this data apply to someone living someplace else in the world? How does the Swedish data apply in Africa? How does this, we have to think about those things when we're thinking about these types of big studies.
Yeah, I mean, the Swedish population is relatively homogenous when we think about it in comparison to sort of California or, something like that, where things are a little bit more diverse. And that's actually one of the biggest issues, I would say, in research in general, is the overrepresentation of some groups and the underrepresentation of others.
What she means by some groups is white people.
Yes, I do.
We do a lot of research on white people.
And white men.
And white men.
Yes.
Yeah. Well, not this study.
And data on white people is not necessarily translatable to other populations because we are genetically and we're different and culturally different and geographic differences and all of those things play into this.
Exposure differences.
Yes.
I also like to remind people that a lot of studies done on primarily white people is also done primarily on upper class or middle class white people. So socioeconomic status is almost always a factor in terms of how our health behaves when responding to certain things. So just keep it in mind.
Yep. Huge impact on your health outcomes is your social economic status. And it really does. And so, can you really utilize this data and apply it to other groups? I think it's pretty limited. So with this particular study, I'm going to get a little nerdy on you for a minute because I think this is really kind of fun.
Yes.
So when we look at a study as physicians, one of the things we look at is what is the study design, meaning how was the study set up? How was it created? And was it created in a way to answer the question that it wanted to answer? And so these big kind of population-based studies where you're looking at a big nationalized healthcare system, you're looking at a huge database where you can track all of these different patient characteristics, also called demographics, and link them to different outcomes and exposures. So these are called cohort studies. And so what a cohort study does is it's an observational study, and you're comparing two groups or two cohorts of people. And you're generally looking at what a particular exposure is, and then what happens to people who are exposed and people who are not exposed to this particular research question you have. So in this particular case with this study, the exposure is the levonorgestrel containing IUD. So they're looking to see populations of people who use the IUD, populations of people who didn't use the IUD, and then you follow them to see if they develop an outcome that you're looking for. And in this case, they're looking for cancers. And you're not experimenting. So you, the researcher, is not giving them an exposure. You're merely just observing what happens.
And a lot of these studies are done what we call retrospectively. So
Mm-hmm.
it's not like you say, okay, you've gotten an IUD, so we're going to see what happens. It's, hey, over the last X number of years, let's see what happened to all the people who got an IUD versus all the people who didn't.
And that kind of works because if you're looking at something prospectively, meaning you're looking at it, we're going to start at point A and I'm going to look forward, it takes a really long time to get the information. But a retrospective study, you can just sit down and say, okay, at this point in time, I'm going to look at everybody over the last 10 years, 20 years, whatever, who had an IUD and find out what happened to them because I have all the data here. So you can actually get answers faster that way because it's just depending on how long it takes you to go through the data and analyze it.
This Swedish study, or actually the authors aren't Swedish, but they use the Swedish data. This study basically was designed, I think it went from like 2005 to 2018. Is that right, Amy?
I think that's correct. Yeah.
So they pulled all the women who used an IUD in that time period, and then they pulled a huge group of women who didn't use an IUD that they could detect.
I mean, it's a huge number because it's so many different people. You're looking over 13 years. So they actually had a really big group of people to look at, which is helpful because, again, the bigger the group, the easier it is to spot differences between the groups, which can be a good thing and can be a bad thing, depending on, again, clinically how this is relevant.
Over 500,000 women who had used an IUD. And then they matched that up with a group of women equally sized as what we call control, the control group. And then they looked at some other exposures so they could try to control for some things. What were some of those exposures that they looked at?
When you're looking at these two different groups, and this is a huge number, right? Because they're comparing 500,000 people who used the IUD with 500,000 people who didn't. And then they want to try to match the group up and make sure that the two groups are similar. So the things they want to make sure that they're similar for are the things that maybe could impact cancer risk, because we want to try to take out any other factors that might impact whether or not somebody gets cancer. And so things that they looked for were education backgrounds, income levels, how many pregnancies they had, age at first birth, because if you have babies sooner or later, sometimes that can impact your cancer risk. They looked at obesity. And they also looked at something that they called hormonal exposure, but they didn't really describe exactly what that was. So I don't really know if that was birth control, menopausal hormone therapy, both, any. So they didn't really get into exactly what that meant.
I was glad to see they didn't just look at breast cancer rates. So they designed this study because there had been previous studies that hinted that there might be an increase in breast cancer. But they also looked at other gynecologic cancers. They looked at cervical cancer, and they looked at uterine cancer or endometrial cancer, and they looked at ovarian cancer as well. So we got a lot of answers out of this one study, or at least a lot of data.
A lot of data, which is interesting. And they also looked at if you had a family history of cancer, would that impact the cancer rates between the groups? They didn't really say what the family history of cancer was. So they didn't say if you had a family history of breast cancer or uterine cancer or colon cancer. It was just if you had any family history of cancer, which is a little bit vague because certain cancers may not really impact your risk of breast cancer and certain cancers might. Now that we've set this study up, is everyone on the edge of their seats to find out what the results are? I am.
Of course.
It's going to be very exciting. Okay, though the big question they wanted to look at was breast cancer, right? Okay, so for breast cancer, they calculated the rates of breast cancer. So there were, for the IUS or IUD group, we call it intrauterine systems or intrauterine devices. So for the levonorgestrel containing IUD, they had 12.4 cases per every 10,000 person years. So remember, Rebecca explained what we meant by person years. Versus in the non-IUD using group, there were 10.94 cases per every 10,000 person years. So we had a difference of about 1.46 cases between the two different groups. This was statistically significant, meaning that when you look at the data and they compare, is this actually statistically due because there is a difference versus could this difference just be because of we don't really know why, but we want to see if it's what we call statistically significant, meaning we've done a test to make sure that this isn't just due to chance. And so, yes, there was a difference, but the absolute risk was 1.46 additional cases of breast cancer in IUD users per every 10,000 person years.
So let's step back. We gave you a fact at the beginning of this podcast that menopausal hormone therapy, we think the progestins increase the risk about one additional case per 1,000 user person years or woman years. This is an order lower than that. So it's 0.14 per 1,000.
Right.
Very small. Just to compare apples to apples, because we
Right.
talk in so many thousands of person years.
Right, exactly. So if there, this very potentially slight increased risk is there, it's even less than the very small increased risk that we would see in people using menopausal hormone therapy.
Yeah. Now, I'm going to say that when they reported this in the press, they said, oh my God, there's a 12% risk increase for breast cancer. And that's because they also calculated a different sort of way to report this, which is a hazard ratio. And the hazard ratio is 1.12. And technically, that means that there was a 12% risk increase. But that sounds a lot scarier than when you actually use the actual numbers.
And it's really important when you're looking at these things and when people report something in the media, when they're saying it's because the media loves to report things in percentage increased risk.
Yeah, it sounds much better.
It's just far more sensational. It's just like, this is going to, splash across the headlines. But you really, for us physicians, the way we look at it is an absolute increased risk in numbers. Like, is this clinically significant? And for me, looking at this,
Meh.
I'm not super excited about it.
What was exciting
Oh, yes.
was the decrease in uterine cancer.
We love that.
So they showed that the IUD or IUS decreased endometrial or uterine cancer. So in the women who used an IUD, they had 0.35 cases of uterine cancer per 10,000 person years. And the women who didn't had 0.52 cases per 10,000 woman years, which if you look at that hazard ratio again, talk about a splashy headline, the hazard ratio on that was 0.67.
Wow.
That's a 33% reduction in uterine cancer. But that didn't make the headline, Amy. Why not?
Because nobody wants to say that an IUD is actually beneficial or helpful. We just want to talk about how it's negative. But the way that endometrial cancer works is it is usually mediated by the impact of estrogen on the tissue that lines the inside of the uterus. And progestogens are very potent sort of antagonists or
Blockers.
Thank
They're
you.
the linebackers of the uterine lining.
Of the uterine lining. I love that. We've got to bring a little football into this. And so progestins do a great job of preventing the impact of estrogen on the uterine lining. And it's very unusual for somebody who's on an IUD to actually develop uterine cancer. So it does very much reduce your risk of uterine cancer, as does birth control pills, actually, because the progestin in there actually does such a good job with that. And we actually will use it for patients who have precancers or early cancers of the uterus who aren't good surgical candidates. And it does a phenomenal job with that.
Yeah. It also reduced the risk of two other gynecological cancers.
I just love this. Tell me everything.
So ovarian cancer, very scary cancer, not a common cancer. So I think we don't think about ovarian nearly as much because it's pretty rare. But ovarian cancer, unlike breast cancer, is often picked up at a very late stage.
Yes.
And very hard to treat. And it reduced that one in the people who had an IUD for any length of time at any point. So this is not people who had it permanently. This is, at some point they had one for 5 days or 5 years. We don't know. But it reduced ovarian cancer down to 0.58 per 10,000 person years versus 0.68. So that's a significant reduction in something that can be very advanced. And cervical cancer was also reduced. And, cervical cancer can be devastating if not caught early. We can catch that early. Everyone should be getting their pap smears
Yes.
because this is something we can detect and treat before it becomes cancer.
Right. Absolutely.
Public service announcement.
We love those.
So, what is the risk benefit ratio here? Like, we're preventing three, maybe slightly increasing one. I don't know.
You have to put the whole picture together, and that's what's super important. And I think so when I'm counseling patients on sort of the benefits, or I'm counseling, for example, my classmates in my Pilates class, and they're complaining about various GYN ailments, and I'll just look at them and say, how many times do I have to talk to you about the benefits of an IUD? I mean,
I know.
I think they're pretty tired of hearing about it. So I'm like, well, when all of you get one, then I can stop talking about it.
Yes, exactly.
It's that whole combination, right, of putting it all together. You have to look at the whole picture. You can't just look at one headline and feel like you get the whole story, because you don't.
Yeah, exactly.
Let's talk about a little bit about the JAMA. There was another study that was kind of similar,
There was. So the one the New York Times actually wrote about was the JAMA study, because I think that's the journal that they follow, the Journal of the American Medical Association.
called JAMA, trying to be hip and cool.
The authors for the JAMA study went to Denmark instead of Sweden.
A very different population.
Yeah, obviously. It's a much smaller study. So they compared 78,000 IUD users to 78,000 non users, but they were hormonal contraceptive users. They only looked at breast cancer. They didn't look at uterine cancer. They didn't look at ovarian or cervical cancer. So we can't tell you how those rates compare, but they found, about the same thing that we just told you.
Mm-hmm.
So again, 14 additional cases in 10,000 woman years. We don't have a lot of context in this study. It's a little less well described. It's what the way they reported it in the JAMA article is as a research letter, which means it's not a full research study. It's like a foreshortened or simpler study. They don't tell you all the details. So we can't tell you exactly everything they controlled for. We can't tell you, a lot of details about the database. But, coming up with somewhat similar risk numbers, right?
And I think the important thing is oftentimes people think of these studies as causation studies, that this causes an increased risk, but it's really looking at an association between things. So
Mhm.
there's this association between IUD use and this potentially very small absolute increased risk of breast cancer.
I say all the time, and I'm sure you do too, association is not causation.
Yes.
And we need to stop confusing those two. Let me give you a real world example. Everyone who eats ice cream will die.
I was not expecting that, dear listeners.
But it's true. If you eat ice cream in your lifetime, you will die. But that's not causation.
No, it is not.
So we can make associations that are not causations. It's just, you need to think about this as yes, we're seeing this, but is the IUD causing it? We don't know based on this data. We didn't take two identical populations and give one an IUD and not give the other and follow them prospectively in a blinded way so they didn't know if they had an IUD. Like, these are different types of studies. They're just telling us about associations.
These are not my favorite kinds of studies. I
Yeah,
feel like they're just, again, we're looking at sort of really minute details. And I like to think about things as to how do they impact my patients? How are they going to impact my clinical practice? How does it impact the person who's sitting in front of me?
right.
Because you're not a statistic, you're not a person in a national database.
You are not a person year.
You're not a person here. You're a person. You're sitting in front of me. And there's a lot of detail with these patients that I don't know. Is there a reason why these patients used an IUD but didn't use something else? Is there something in their history you can't get from a national database that dictated why that group was in there? And maybe that reason, the reason why they got the IUDs, is why they have a slightly increased risk of breast cancer.
Let me give you an example that really plays to this question. Maybe they went to their doctor and they said, hey, I have a genetic risk for breast cancer. And their doctor said, oh, then we shouldn't put you on birth control pills, but the IUD gives you a lot less hormone, so let's do that. They would have a higher risk at baseline. but we don't necessarily know that. Or maybe they said something else like that, but that's not necessarily an example from this study, but that's how that can play out.
Right. And physicians, we are, your doctor is influenced by these different things. And our motto, the oath we take, is to first do no harm. So if we have two viable options in front of us and there's something that we're worried and concerned about, we're going to lead you down another path. We just don't know, how that fork in the road or how that decision is therefore going to impact you later down the road. But at that time, we're trying to make the best decision that we can and help you make the best decision that works and makes the most sense for you at that moment.
Yeah. When I'm talking to learners about this type of study, and I agree with you, it's not my favorite kind of study either. But when I'm talking to learners about it, I tell them this is the type of study that should formulate questions. This shouldn't dictate our practice. We use these big database studies to say, hey, could there be a link here? And then the next important step is to say, how can we better study this?
Mm-hmm.
How can we do a prospective study that gets at that question where we can control for more things? Now, that's not always possible, right? Some things we can't prospectively study, or it would be too big, or it would be dangerous for patients. So it can't always happen. But really, this type of study is really designed to sort of help us think about what we should do next to figure this out.
Yeah, I think that's a really great way. If we had unlimited resources, what could we do? And maybe at some point you can design that study and maybe we never actually get the details on it, but I think it's just another piece of the puzzle. It's another piece of information to put it all together.
It's important to think about studies that way.
Yeah.
Now, I did want to sort of end on a perimenopausal note,
Oh, yay.
which is, why are we talking about IUDs in perimenopause? Do we use them in perimenopause? And why might we use them in perimenopause?
Oh, do we use these in
Oh my God,
perimenopause? I mean,
so often.
single greatest thing that's ever happened to me. So, what I love about the IUD and why I love using it in perimenopause is we're often balancing a few different needs. So, we're balancing what's happening with your perimenopausal symptoms and we're balancing your need for contraception. And most people will say, I don't need contraception. I'm done having babies. I'm like, well, you might be done having babies, but your body doesn't know you're done having babies.
Right.
And until you're in menopause and you go a full year of no ovulation and no bleeding, you can still get pregnant. Now, the odds go down, but they're not zero. And if you look at the distribution of unplanned pregnancies in this country, we've got the teenagers that everybody thinks about, and then we've got the ladies in their 40s.
It's a second puberty in more than one way.
Yes. Given that, you really do need to think about contraception. So what I love about the IUD, and there's other ways that I like to contracept at this time as well, but the IUD is one of my favorites. And the reason is because it can treat your irregular and unpredictable bleeding. So it does a
Yes.
great job with that.
The Mirena IUD is fantastic for that. I think, what is
Wonderful.
it, 70 or 80% of women who have an IUD have no bleeding whatsoever. So their periods just disappear. Doesn't stop you ovulating.
No.
Still have hormones around. You just don't grow any lining because of the linebacker. And so there's nothing to bleed.
I mean, this is your like 350-pound linebacker situation.
Yeah.
Like this is
Definitely.
Yeah, exactly. So love the IUD for that. And you can pair it with estradiol or estrogen therapy for your other menopausal symptoms that you're having, because the IUD is not going to take care of your hot flashes. It's not going to take care of mood or sleep, but you can add other things to it to address it. And they pair really beautifully together. My one caveat that I always like to mention is that you can use the IUD for birth control for up to 8 years. If you're pairing it with estrogen for menopausal and perimenopausal symptoms, we only have data so far on using it for 5 years. So although it probably is okay to use it longer, we just don't have the data on it. So you might as well just get it switched out so we're not like worried about that particular issue.
Right. And that's actually an important point because we do know that the levels go down over time. It's releasing less and less progestin every year.
Right.
And we don't know exactly where the line is in prevention. And there are some older studies about smaller, less strong IUDs for menopause that maybe didn't protect as well. So 5 years, just switch it to 5 years.
Yeah.
For now.
For now. And I'm hoping to do a study at Stanford. This is a question I'm literally dying to answer because it combines my two obsessions.
We are all dying to answer this question.
my love of menopause and my love of contraception. So we got to put these things together. But so stay
Mhm.
tuned. Maybe we'll have something exciting to report at some
Yeah,
point.
and so Amy will try to get it done at Stanford. I've talked to the drug company that makes this IUD multiple times and said, you need to do the study. And they're like, yes, we get the question. We understand. That's not where we're headed right now.
Right.
But I'll keep on them.
Maybe somewhere down the line I'll care about women's health, but
Yeah.
So we love it for contraception. We love it for bleeding. We love it for menopausal hormone therapy. And basically, what we're using it for there is protection of the uterus because estrogen, again, stimulates the lining of the uterus to grow. And you need the progestogen if you have a uterus to counterbalance it.
Yeah. So we're preventing that precancer that Amy mentioned earlier.
Yep,
It's also important to recognize that in perimenopause, when the hormones are fluctuating so wildly and you're not always ovulating every month, you sometimes spend 2 or 3 or even 4 months with lots of estrogen around because your body's trying to get an egg out and no progesterone because you haven't gotten the egg out. And so women in perimenopause, because of that, are at higher risk for precancer and cancer of the uterine lining.
yeah,
So if you're having these weird bleeding intervals, this could be a great way to not only prevent the really heavy bleeding that can come with those intervals, but actually prevent yourself from being at higher risk for precancer or cancer. And as Amy mentioned before, it also treats some of those precancerous states or even cancers in women who aren't good surgical candidates. So it has a lot of benefits in perimenopause.
I love it. It's
So do
just,
I.
it's a total winner. So again, we have to weigh all the risks and the benefits, but we really wanted to put this podcast out or
Mhm.
this episode out today because I think those headlines can be very frightening and very scary. And if you don't really understand, because it's not explained in the article and you're not a doctor and this isn't what you do every day, I think it can be really overwhelming. And so there's so many mixed messages and there's a lot of fear mongering in the media related to women and hormonal therapy that they're taking. I mean, reporters aren't dumb. They know how much the WHI or Women's Health Initiative study, all the press it got and the drama. It's like, oh, well, let's see what other, pot stirring that we can do. And I don't think it's necessarily there's not like malintent, but I just think that's kind of been conditioned.
Well, but also that reporter read the abstract of the study and it said 12% increase in breast cancer. And that sounds scary. And they're thinking, I got to let women know this.
Exactly. It may come from a good place. It comes from a place of trying to get the information out there. So,
Right.
but we're just here to kind of set the record straight.
There you go. And I think we should leave our listeners with one last fact, which is that what is the birth control method of choice of all OBGYNs?
That would be the hormone containing IUD.
I think they did a study once, and what was it, like 70% of female OBGYNs had one of these?
It was super high.
We love this thing, and we do it to ourselves.
We do. I think I'm on number 3, 4. I don't know. I'm not sure.
I had 4 of them
Right.
before my uterus got
Before
taken
your uterus. Right.
but and my uterus got taken out with the Mirena IUD in it.
Yes, absolutely. I feel very strongly that mine needs to stay with me for quite a long time. So,
Yeah.
as my girlfriends would say, they're like, "Oh gosh, if you ask Amy what she's going to recommend, we know what she's going to say."
So, Amy, a lot of people talk about IUDs nowadays also in association with the pain of insertion and pain management and all of those things. And this podcast is really about risks, not really about pain and how they're used and how they're placed. But we are going to do a whole podcast on contraception and we will absolutely address that and how to ask for pain control if you're worried
Right.
and how does it feel. I think both of us can attest it feels different each time you get one. So it's not even like we can necessarily say it always feels like this, but we will absolutely address that because it is important to take women's pain seriously,
Right.
which both of us agree with. And there are lots of things that can be done to make it a much less painful procedure.
So, we hope, dear listeners, you enjoyed this episode. We hope that you are no longer afraid if you were or concerned or worried about using an IUD. And we hope we've shed a little bit of light onto why we like to use them in perimenopause. We keep talking about it. We are going to do a series of episodes on the WHI study or the Women's Health Initiative study.
Coming up very soon.
And we definitely will be talking about that in detail because it's really important to understand the pros and the cons of that study.
Yeah.
And the IUD won't be part of that, but we will be talking about hormone therapy in more detail.
And breast cancer risk.
And breast cancer risk and the pros and the cons and sort of the limitations of that study and kind of what happened back in the early 2000s when that was released. So to be continued.
And remember, you're not crazy. This is really happening.